This is the Registered Behavior Technician course presented by Shaza Attar. The course content was created by Shaza Attar and is the property of Autism Therapy and Training, Inc. All rights are reserved. This training program is based on the Behavior Analyst Certification Board 2018 RBT Task List 2nd edition and is designed to meet the 40-hour training requirement for the RBT credential. The program is offered independent of the BACB. Remember, in each class, we will have our active listening, a quiz, and a competency assessment.
Welcome back, everyone. Today, I'll be discussing autism and neurodevelopmental disorders. If you currently work in the field, in an ASD classroom or an autism center, you might be very familiar with autism. But for many taking the 40 hours of training or having recently landed themselves a job in ABA, they may not know much about autism. So what is autism? How does it differ from other developmental disabilities? So today, I'll go through this in as much depth as I possibly can. But before I jump into that, I want to review developmental milestones. Why? Well, it's important to know how children often develop. Now, milestones for children vary, and there isn't a set age for development, but children will often learn things around the ages given. This is important because when children do not, then we can possibly flag these as warning signs. Many parents will often speak to their doctor when children are not reaching the developmental milestones. Teachers will often speak to parents when they notice certain things as well, which is important. Developmental milestones are a guide for educators and parents. I always caution those reading them and using them because children develop at different rates. For example, a child may respond to their name at about 9 months, but some kids may start responding to their name at 4 months or 11 months. We want to use the milestones as a guide so that we can be aware of any warning signs. So at 6 months, an infant begins crying differently to access certain reinforcers or items. They may cry one way when they're hungry versus when they want mommy. They will watch your face and attend to you when you're talking, smiling, laughing, and imitating some sounds. When I worked with my little girl Maggie, her mom had mentioned that she was concerned about her daughter at about 6 months. She said that she noticed that Maggie didn't turn her face and look at her when she had those one-on-one moments with her, and that Maggie looked off to the side and didn't really notice her mom. And that was a real concern for her. She did have that internal motherly feeling that something was not right. At about 9 months, infants begin responding to their name, responding to environmental sounds like a ringing of a phone or someone at the door knocking. They begin to understand no. Here, we may see an infant making sounds to get things, playing social games such as peekaboo, enjoying people, and babbling. Often I coach parents that are worried about their child's development at the 9-month mark for them to play these social games and do some song fill-ins even if the infant doesn't fill in, but exposing them to these back and forth type interactions and producing sounds during play. So producing ba 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 while eating, or choo choo while playing trains, or uh-oh when something falls. Selecting sounds associated with actions and movement is helpful. At 12 months, we begin to see the toddler follow one-step instructions. Sit down, come here. My nephew, who is just over 12 months, if his mom says, set the mat, he will take the tablecloth and put it on the floor. If she's telling her older kids to vacuum, he will go to the vacuum and pretend he is cleaning. At this age, when someone points to something in the room, the toddler would look in that direction. One of the ABLES-R items is that the learner can look to things you point to. These joint attention interactions are very important in a child's development, specifically that social development. At 12 months, toddlers begin waving goodbye, bringing toys to show you, combining sounds as though they were talking, and looking at books. At about 18 months, we start to see understanding of basic concepts of in and out, off and on, points to several body parts when asked, uses at least 20 words, responds with words or gestures to simple questions. Where's Teddy? What's that? Demonstrates some pretend play with toys. Give Teddy a drink. Makes at least 4 different consonant sounds, B, N, D, G. Enjoys being read to and looking at simple books with you. Points to pictures using one finger. Again, when I think of typically developing children that I've been around, mainly my nieces and nephews and children that I've worked with at the daycare, you see a wide range of development. My first niece, when she was about 15 months, she was talking in 3-word sentences, answering questions, and so on. Now, mind you, some were memorized based on practice with her family. One of the cutest things we used to ask her, and her response was adorable, was, "What does Daddy buy at Tim Hortons?" And she would say, "Coffee." And we would ask her, "What does Mommy buy at Tim Hortons?" And she would say, "Tea." And we would ask her, "What does Layla buy at Tim Hortons?" And she'd say, "Bagel," but spontaneously would say, "No Timbits," because they making fat. It was the cutest thing because she knew that her parents would say no to Timbits, and her mom had given her an explanation as to why. So it stuck with her and she used it. Today she's over 21 years old and we still share these stories with her. But I had a nephew that didn't talk and he was about 24 to 30 months and I got worried and I started to pair sounds and doing a lot of actions and words. His language then emerged and took off. Today he's 14 years old and talking beautifully. At 24 months, you can see here that children are following more complex instructions, using more words, pronouns, combining words, imitating, forming sentence, following 2-step directions, go find your teddy bear and show it to grandma, uses 100 or more words, uses at least 2 pronouns, you, me, mine, consistently combines 2 or more words in short phrases, daddy hat, truck go down, enjoys being with other children, begins to offer toys to peers, and imitates other children's actions and words. People can understand his or her words 50 to 60% of the time. They form words and sounds easily and effortlessly. They hold books in the right way up and they turn the pages. They read to stuffed animals. They scribble with crayons. Children are understandable and can communicate what they want or don't want. My nephew, who is just over 24 months, would tell me not to leave, that he wanted me to stay longer. He'll tell me to be quiet or that I'm not listening. What's amazing is that these are things that someone has said to him, but to be able to use it appropriately in context is the amazing part in development. Really, children are not taught to do this, but acquire it through interaction and observation. At 30 months, we see more words in the child's vocabulary. They start using action words, they show concerns for other kids, play is more developed, understands the concept of size, big, little, and quantity, a little or a lot or more, uses some adult grammar, 2 cookies, bird flying, I jumped, uses more than 350 words, uses action words, run, slip, fall, begins taking short turns with other children, using both toys and words, showing concerns when other children get hurt or sad, combines several actions in play, feeds doll, then puts her to sleep, puts blocks on a train, then drives the train, drops off blocks, produces words with 2 or more syllables or beats, banana, computer, recognizes familiar logos and signs, stop signs, things like that, remembers and understands familiar stories. So again, the idea is to recognize that developmental milestones are a guide and children develop at different rates. but we want to be aware. If you're a parent or a daycare teacher, you may find that you're a bit worried about a toddler. It's important to communicate that to the parent if you're the teacher, or speak to your doctor if you're the parent, so that you have that open communication and understanding. If I asked you today to explain autism to me, what would you say? Take a moment and think about that. Autism spectrum disorder is a neurodevelopmental disorder. That is, when the central nervous system is disrupted. The central nervous system is responsible for sensory information and responding accordingly. It consists of two main components. The spinal cord serves as a connector between the brain and the rest of the body, and the brain is responsible for combining and coordinating sensory information and body function, both consciously and unconsciously. Some things we don't control, and they just occur, such as breathing. Sensory information is transmitted through the central nervous system. As we talk more about autism, you'll begin to see how the central nervous system is impacted and why many of our learners may have difficulties with sensory information coming into the body. Some children may require sensory support to help them. For example, some children I work with require deep pressure or the use of things like a trampoline to help them regulate any sensory issues. Sensory experiences include touch, smell, taste, sight, sound, balance, and body and space. Sensory integration therapies assume that a child is under or overstimulated by the environment. As part of ABA or IBI therapy practices, we may include some sensory times to support and replace any other types of behaviors with the same function. For example, if a child was engaging in spinning around in circles, we may get them a swing and allow them to access that so that it can reduce the spinning behavior. Some activities may include swinging, jumping on the trampoline, listening to music, and so on. These activities would depend on the type of sensory needs. Autism is not the only neurodevelopmental disorder. There is attention deficit hyperactivity disorder known as ADHD, communication disorder, intellectual developmental disorder, motor disorder, and specific learning disorders based on the classification set described by the DSM-5. The DSM-5 is the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, which has outlined autism spectrum disorder as being characterized by a lack of social interaction, verbal and nonverbal communication that is often diagnosed within the first 3 years of life. It has outlined some distinctive social behaviors that include avoidance of eye contact, problems with emotional control or understanding the emotions of others, and a markedly restricted range of activities and interests, as well as repetitive behaviors. I want to discuss each one later so you have a good understanding of what each one means or looks like. Before the DSM-5, practitioners and doctors would talk about Asperger's, autism, PDD, and OS, but now they are all classified as autism spectrum disorder. The prevalence of ASD has increased in the past 2 decades. This is partially due to the changes in the DSM diagnostic criteria and younger age of diagnosis. Studies have shown a male predominance. ASD affects 2 to 3 times more males than females. There are different reasons why researchers think ASD is more prevalent in males. Some say that females are under-recognized. I know from practice in the years that I've been working in the field, I can say I've had a small handful of girls in therapy compared to boys. A Swiss psychiatrist known as Paul Eugene Bleuler used the term autism to define the symptoms of schizophrenia for the first time in 1912. He derived it from the Greek word autos, which means self. Later, around 1938, Hans Asperger's adopted Bleuler's terminology, but to describe child psychology. He reported about 4 boys who did not mix with their peer group. The boys also showed specific unnatural movement and habits. Asperger's described this pattern of behavior, and this was later named Asperger's syndrome. In 1943, Leo Kanner was the first to introduce infantile autism and had reported about 8 boys and 3 girls who had difficulty forming contacts with people. For years, experts have been talking about whether autism is genetic or environmental. Many believed for long periods of time that vaccines had something to do with autism. And I think people still believe it does. Could it be that vaccines are given right around the same time that a child is between 1 and 3 years of age? Is it a coincidence, or is there a correlation? Are there environmental factors that trigger autism? You may hear many people speak of gluten and casein-free diets. Some talk about keto diets that have lessened the severity of autism. Research is starting to provide some answers to help us understand autism a little bit more. Genetic causes, including gene defects and chromosomal anomalies, have been found in 10 to 20% of individuals with ASD. Siblings born in families with ASD were 50 times more likely to be at risk of being diagnosed with autism, with monozygotic twins at rates of 82 to 92% compared with 1 to 10% in dizygotic twins. So we can see more of a genetic factor when we look at twins. But we also know that there are diverse environmental causes, including prenatal and postnatal factors, that can contribute to ASD. Prenatal factors related with ASD, such as viral infections, low birth weight, abnormally short gestation length, were some of the factors that may have contributed to autism. Reported postnatal factors associated with ASD include autoimmune disease, viral infection, mercury toxicity, and others. Let's do a Scrabble word before we jump into autism and talk about all the features. The word is chon, spelled C-H-O-N, which is the monetary unit of North Korea. Again, the word is chon. Okay, take a quick stretch and let's get started. Individuals diagnosed with autism spectrum disorder often have challenges and impairments in language. That is, grammatical structures tend to be immature. They often engage in repetition of words and phrases, repeating jingles and songs. Loss of language has often been reported by many parents. Many children that I work with are often nonverbal, which means they have no sounds or words. We start off with basic language training, which may be sound production, and later development into words and phrases. When children aren't making sounds or talking at all, this is when parents often get very worried. Although delayed language may not be a diagnosis of autism, it is usually a warning sign to look out for. Individuals with autism often struggle in social skills. Again, this is an area many parents come to us for. Usually they tell us that their son or daughter are unable to form peer relationships. They may show no interest in peer relationships or show a lack of understanding in social interactions and conversations. Difficulty with social games and play, often prefer playing independently. Now, it's important to understand and respect an individual. Someone who doesn't want to play with others versus someone who doesn't know how to play with others. It's okay for children, youth, and adults with autism to be independent and to do things alone, but teaching them the skill of how to interact with others is an important life skill. They will need these skills in their future, a future job, future schooling, relationships, and so on. You may have seen individuals with autism engaging in repetitive behaviors and movements of hands or bodies, such as clapping, finger flicking movements, movements of the body, such as rocking, swaying. These can sometimes be very intense for our learners. You can find a learner shaking their hands vigorously. Sometimes you'll find learners shaking their head. These behaviors may happen for different reasons. We'll talk about functions of behaviors in a later class. But sometimes individuals do it when they are very excited. Sometimes they do it to escape a task. Sometimes when they're alone and it gives them a good feeling. These are known as self-stimulatory behaviors. We all do these. You may twirl your hair or tap your pen. As I mentioned before, we often find individuals with autism stuck in their ways, inflexible with routines, insist on sameness. If something in their routine changes, they may engage in problem behavior. We often see specific interests such as letters, numbers, dates, fascination with rapid moving objects like spinning wheels or opening and closing doors. They may have attachments to objects such as a specific doll or a rubber band. I worked with a little girl who was about 4 years old that had an attachment to her necklace. If she didn't have that necklace, she wouldn't sleep at night. One day at the center, the therapist took it off and they put the necklace in their pocket. Well, the therapist forgot about the necklace, sent the little girl home at the end of the day. Later that evening, I noticed an email from the girl's mom asking for the necklace. It was about 9 p.m. on a Friday night. I had to email the therapist to find out what happened. I notified the little girl's mom, but by then they had already gone out to Walmart nearby and purchased a similar necklace. These are real life situations that happen. You may be wondering, why would a parent go to the extent of getting another necklace? Why not just tell her to wait until Monday? Well, the reality is it can be very difficult for the child and for the parent. She wouldn't have slept, and it would have impacted their weekend, sleep, and that's not something they were ready to deal with. So it's important as a therapist to be aware of that and not to take it lightly. A parent's concern is a parent's concern. It is probably affecting their life greatly. These are things that we should definitely think about and ensure we program for. Individuals with autism may also have diet issues. Many children may have very specific eating habits. They'll only eat French fries or all the red ones. Sometimes their diet is very limited, which can also impact their overall ability. With less nutritious food, this may impact the learner's cognitive abilities to stay focused during teaching sessions. It takes a lot of effort to learn, and you may find that the learner gets very tired after a therapy session. So that's something to consider. Or some may engage in pica disorder, which is eating items that have no nutritional value, non-edible items such as dirt, paint, feces, and so on. I do believe that diet has an impact on anyone. If you don't feed your brain the right foods, how can it perform at an optimal level that you want? If you have ever tried intermittent fasting, you'll find after 12 hours you start to feel weaker. You start to lose focus, and it's harder to pay attention. So this can happen to our young learners too. So you need to think about when your client has eaten, what they're eating, maybe working with the family to support better eating habits. These are things that you and your team can discuss for each learner. Individuals with autism may also have oversensitivity to light, sound, sense, so you need to be aware of that. You need to adjust the environment to meet their needs and work towards adding those elements into their environment slowly. For example, we had a learner who was sensitive to sounds. He didn't tolerate the electric sharpener that we had, or fans, or other things that we had in the classroom. So you can slowly introduce them into the environment at the center. We ensure that all staff are scent-free. Heavy scented perfumes can be very bothersome to the client, and we need to keep that in mind because we wouldn't want that to affect their learning. Lastly, those diagnosed with autism can have sleep disturbances. They may wake up at night, have a difficult time falling asleep, and we all know not having a good night's sleep can really impact your day. So imagine your client not sleeping well at night, then coming in for their therapy session. Well, that may not go so well. It's really important that you get an update from the parents about the child's night if you're working with that child. Find out if they've slept, how many hours. because it can shed some light into the reasons why they may be engaging in problem behavior. I'll definitely talk about this more in other classes as we get further into therapy and things to watch out for. All right, so let's do the quiz to give you a break from all this information. Then we'll get back into talking about autism and the brain. Good luck. What does ADHD stand for? A. Attention disorder hyperdeficit. B. Attending delay hyperactivity disorder. Or C. Attention deficit hyperactivity disorder. And the correct response is C. Attention deficit hyperactivity disorder. Children with autism may eat non-edible items. This is known as A. Anorexia, B. Pica, C. ADD, or D. None of the above. And the correct response is B. Pica. Children with autism may show which of the following? A. Be inflexible with routines and insist on sameness. B. Have specific interests such as letters, numbers, and dates. C. Have fascinations with rapid moving objects like spinning wheels or opening and closing of doors. Or D. All of the above. And the correct response is D. All of the above. What is autism? A. Disease. B. Syndrome. C. Disorder. D. All of the above. And the correct response is C. Disorder. What is a feature of autism? A. Repetitive behaviors. B. Language delays. C. Social deficits. Or D. All of the above. And the correct response is D. All of the above. What is autism spectrum disorder? A. A genetic abnormality. B. A neurological disorder. C. An environmental syndrome. Or D. All of the above. And the correct response is B. A neurological disorder. Twin studies have shown A. Lower rates of autism. B. Higher rates of autism. C. Inconclusive results. D. None of the above. And the correct response is B. Higher rates of autism. Autism is greater in A. Boys. B. Girls. C. No difference. And the correct response is A. Boys. So you have an idea about autism now, some of the features that are associated with it. But what about the brain? What's happening inside the brain that is impacting autism in this way? Well, you can imagine how many researchers have been studying this. Can they pinpoint areas in the brain that are affecting individuals with autism? Studies have shown links to the frontal and temporal lobe, that these areas of the brain are affected. There is a strong association with these lobes with social and aggressive behaviors. Small neuronal size and increased cell density was detected in ASD patients. The amygdala, which is found in the temporal lobe, has two main functions. The first is eye gaze and the second is face processing. These may explain why individuals with autism have a difficult time with these skills. Studies found that when the temporal lobe was damaged due to a tumor, individuals began to exhibit autistic symptoms. With all these studies and continued research, there is much for us to learn. There are many unknowns, and with time, these may be answered. The prefrontal cortex is responsible for high-order cognitive abilities, language, social and emotional behavior. Individuals with autism have deficits in these areas. Studies have found that ASD patients had faster rates of growth in the frontal lobe region. We know that autism is a complex disorder. As I said before, there is much research continuing to shed some light into causes, genetics, and the brain. With that being said, it is important to understand the features, causes, and the role of the brain, but ultimately more important to understand our role in how teaching is going to impact our learner. We know many factors can influence learning. Food will impact the brain, brain structure, or damage to the brain is going to impact learning. So what happens with individuals with autism that have a dual diagnosis? What happens when we are faced with other developmental disorders or syndromes? I want to briefly talk about other developmental disabilities that you may encounter in practice. Attention deficit disorder and attention deficit hyperactivity disorder refer to a hereditary biochemical disorder that impacts an individual's abilities. The symptoms start in childhood and often carry on to adolescence and adulthood. According to the National Institute of Mental Health, 3 to 5% of American children suffer from ADD or ADHD. According to Statistics Canada, 2.1% of children between the ages of 6 and 11 are diagnosed with ADHD. The ADD definition has changed over the years. The Diagnostic and Statistical Manual of Mental Disorders officially changed how professionals refer to ADD and ADHD. Before the change, the DSM used the phrase ADD with or without hyperactivity to differentiate between the two types. However, the DSM-5 diagnostic criteria began using one term, attention deficit hyperactivity disorder, or ADHD. Researchers don't know the exact cause of ADHD, but they know that it often runs in families. There is a strong indication of genetic factors that makes a person predisposed to ADHD. Other studies indicate environmental factors that could cause ADHD symptoms. This is very similar to what we say about autism as well. There may be a genetic component in individuals and they're predisposed to the disorder, but environmental factors could be playing a major role as well. Research has shown possible links between ADHD and environmental conditions such as tobacco and alcohol use during pregnancy or exposure to high levels of lead in early childhood. But of course, more research needs to be done. Indicators of ADHD include poor impulse control, hyperactivity such as they can't sit still, difficulty focusing on immediate tasks, and inability to pay attention to instructions, difficulty forming and maintaining friendships, and receive poor evaluations at school due to their behaviors. Individuals with ADHD have some social deficits such as interrupting conversations and speaking out of turn. Not all children exhibit hyperactivity. Some children may engage in daydreaming and miss key details and information. They become bored quickly while working on tasks and may move slowly. Since they can sit quietly and don't exhibit overtly poor behavior, parents often overlook the possibility of ADHD. Children may be diagnosed with a communication disorder. These can be stuttering, language disorder, social communication disorder, and speech sound disorder. A child may be diagnosed with childhood onset fluency disorder, also referred to as stuttering. That is when you will notice that an individual may repeat sounds or words during speech. It may be normal for children to stutter between the ages of 2 and 5. However, stuttering that persists beyond that or that causes considerable communication issues may require treatment by a professional. The DSM-5 lists some characteristics or features of stuttering as the following: pauses within words, filled or unfilled pauses in speech, using things like or extended periods of silence during speech, prolonged consonant and vowel sounds within a word, repeating whole words over again before moving on to the next word in a sentence, excessive physical tension when speaking, substitutes words to avoid more difficult problem words. The term language disorder refers to a condition that involves problems processing linguistic information. Children with language impairments have issues that involve grammar, semantics, or other parts of language. Others may understand them, but they have problems getting others to understand their meaning or comprehending the meaning coming from others. Difficulty understanding what others say. Signs of language disorder are problems following spoken directions, problems organizing thoughts, having difficulty putting their words into sentences. Sentences may be short, simple, with incorrect word order, have problems finding the right words when speaking, and using placeholders like or as I said before. And their vocabulary may not meet the expected grade level. Leave words out when talking. Use certain phrases repeatedly. Repeat parts or all of questions. Use word tenses improperly. Social communications disorder involves an impairment of communication in natural social settings. People with social communications disorder have problems using verbal and nonverbal communication and cues. The symptoms of social communication disorder begin to show up in early childhood and can cause problems in social, academic, and occupational areas. Some of the symptoms are problems using communication, verbal and nonverbal, in social situations, challenges adapting communication styles to fit the context or the style of people the person communicates with, problems following social rules like taking turns during conversations, difficulty understanding implied messages. Intellectual developmental disorder refers to a condition in which a person has certain limitations in intellectual functions like communicating, taking care of himself or herself, and impairments in social skills. We begin to see delays in many areas. Some delays such as sitting up, crawling, walking, and even talking. They may have trouble remembering, difficulty with social rules, difficulty understanding the consequences of actions, trouble solving problems, and thinking logically, impairments in reasoning, planning, abstract thought, judgment, academic judgment, and so on. In the DSM-5, motor disorders are listed in the neurodevelopmental disorder category, which was previously known as tic disorders. The term tic refers to sudden movements, twitches, or sounds that people perform repetitively. These tics are really out of the control of the individual, and individuals with a motor tic disorder may blink repeatedly. Someone with a vocal tic might unwillingly make grunting sounds over and over. The 7 motor disorders listed in the DSM-5 include developmental coordination disorder, stereotypic movement disorder, Tourette syndrome, also called Tourette's disorder, persistent vocal or motor tic disorder, provisional tic disorder, other specified tic disorder, and unspecified tic disorder. I won't discuss each one specifically, but these are good to know when you're working with your clients. Since you may not be working with individuals with autism only, some individuals may have a dual diagnosis or may have different diagnoses, but you may see resemblances to autism. Lastly, specific learning disorders is when a child's ability to read, write, and do math may be affected. A specific learning disorder is different from intellectual development disorder in that Children with learning disorders usually have at least average intelligence, but are still not able to acquire academic skills expected for their age. A child may have impairments in decoding words, understanding the meaning of what is read, spelling, expressing himself in writing, doing calculations, and mastering mathematical reasoning. Specific learning disorder is a relatively new classification which groups dyslexia, reading-related issues, and dyscalculia, math-related issues, in one. As I said earlier, I don't want to talk about each one in depth since I specifically work more with children that have received a diagnosis of autism and some with ADHD. But it's important to know that there are other diagnoses out there and the features may be different. Again, a diagnosis is important in understanding the learner, but the ultimate goal is to teach, and that is our job as practitioners. So we don't need to focus on the label or diagnosis. As I've highlighted in today's talk, autism is a complex disorder, and we're learning so much about it, but most importantly, we know that so many children with autism can learn and have done so well with therapy. We know that children that have received intensive therapy under good supervision can make great gains. In my own practice for years, I've had learners start therapy as nonverbal 2-year-olds and leave my program communicating, playing with their peers, and so on. This is exciting for the team and parents and something that keeps us going. I hope that your journey as an RBT allows you to experience some of these great moments, but also to learn to see every little improvement as an improvement and success. We want to celebrate those successes, whether they are big or small. We want to share those successes with parents and others because it can sometimes be difficult to see the positives. I always tell families and therapists that I don't have a crystal ball and I don't know what the future holds. But I do know that we will work very hard to do everything we can to help the learner. So keep that in mind. We can't promise anything, but we can give 110%. Thank you for joining me today, and I'll see you at the next class.